So yeah, I thought I would start with this slide because last year in the similar course to this in Paris, I was asked to talk about the 2006 guidelines and a detailed fetal echocardiography. So this one was one of my slides which referred to the first guidelines, which was divided really into a basic screening and an extended basic screening. But there was always, if technically feasible, you have a look at the vessels. And I said at that stage there was an update in progress, and that perhaps I would come to the next meeting, and so here I am. And this is the title of today's presentation, it's the new ISUOG guidelines. But I shouldn't really start with that one, and I'm going to change my first slide again, because this is not my work, as Rabi said, it's a work of quite a number of people. We have been working very hard and disagreeing a lot before we came to an agreement as to what should be a sensible guideline that would apply in general to a lot of countries all over the world where the rules are different for screening and rules in terms of legal aspects are different as well. So the new guidelines are really not entirely new. They are revised and updated from 2006, and they are based on our current knowledge, so therefore it will constantly change. There will be another update in a few years. But the new recommendation is much more stronger than we had before. Is that the outflow tracts really need to be added to routine screening. How we do that is a different question. So would we need guidelines if we had all our patients with lots of amniotic fluid, all nice and happy in a good position, and within a 2-second, we would have a transverse sweep from the abdomen to the three-vessel trachea view, and it would be very easy. But we do need some kind of a structure to see the heart. I'm not sure how the clips are projecting with the lights. Can you see them? So now we're all familiar with this baby that is, you're trying to prod here, prod there, until eventually you see there is somewhere there where the heart is, and then you have to work on the image to improve that. Or you have a patient referred, BMI of 41. This baby's alive. And so the mother. So how do we approach these patients when we have to see the fourth chamber and the vessels? Well, the first thing is to find the heart. And I'm not joking, because really sometimes it is difficult to find the heart in a position that will give you the information you need. When you find it, you need to ask yourself the question, is the heart normal? But that's the main thing. You have to demonstrate normality in order to try and exclude an abnormality. And like most things, we do a structured approach to assess the fetal heart. And you have that in your mind. You might not necessarily tick all the boxes routinely if the baby is very easy to scan, but in a difficult patient, you do need to go sequentially through quite a number of things. So finding the heart. First thing is, don't panic with your ultrasound machine. You do need to know your equipment, which buttons to press, how to improve the image, how to get the heart, the image you want on those babies that are difficult, on those women that have a high BMI and so forth. It's not all going to come straight away. So why am I talking about all of that? That's because coming to our first aspect of the guidelines, which are general considerations. Now, things you have to know before you actually put your probe there and try and see the heart. Well, what's the best gestational age? And I'm going to go through this rather quickly because you know that very well. Well, it's best performed around 18 to 22 weeks, but if you're good at first trimester, if you like looking at that, there's nothing wrong with that. If in your country people don't come for screening, you will have a look at the heart later on, you can also see the heart later on. Technical factors. Choice of transducer, you need to know which transducer you're going to use, be familiar with them, which frequency. You can use all sorts of post-processing harmonics that your equipment allows you to. Should also narrow your field to increase the frame rate. High contrast, a lot of these come with a cardiac preset if you have that on your equipment. Low persistence because of the very fast heart rate. Single focus. So we don't want to think about all of these in all patients, so have a preset that allows you to do everything. Use Zoom to see the structures very clearly, and CineLoop. And I think that's an understated use of the machine. This is just to make sure you are still awake at 8:30 in the morning. So just keep an eye there. Do you know what was that? I'll do it again. Now make sure you're awake. What is it? It's a car, do you agree? What color? Very good. Have another look. Oh, well, I did it before I meant to. I was going to ask what number, and I bet no one of you knew what the number was. Sorry, I pressed my button before. Now, that's the point about the CineLoop. Yeah, you have to stop, slow down, review your image. Because if everything is very clear, you're not going to miss very much. But you will see, particularly when you come at the end of the day to look at some difficult atrioventricular septal defects, that if you don't slow it down, if you don't look with attention, you are going to miss. And that's what we don't want to happen, because we're talking about screening. So back to the cardiac examination. And our structured approach will take things that have been published now for a number of years, but now is part of our official guidelines, is that the 5 axial views, starting from the abdomen, going all the way up to the right, to the upper mediastinum, are the best ways to screen for cardiac abnormality. And this is, if you do a stick, a lot of you do, if you think of doing your transverse sweep on the stick, just do it slowly and then looking at all the details from the situs through the 4 chamber up to the 3 vessel and trachea view. Like I'm doing with this clip, which is a 2D image. Do it slowly, pay attention to look at the valves and the outflow tracts. And I'm going to take you through now, between now and the rest of the lecture, through this clip, more or less, and dissect it into the various short axis views. So if we start with situs and 4 chambers, well, why is the situs important? We do have more general aspects of the 4 chamber, which we take for granted, but it needs to be assessed in every patient if we're looking for cardiac abnormalities. So first, we talk about laterality and make sure the heart and the stomach are on the correct side, i.e. on the left side of the baby. And for that, I don't need to tell you how to identify fetal position. And perhaps you do that if you find a baby that has talipes. You're going to work out if it's right talipes or left talipes. But for the heart, really, you don't have to find an abnormality to identify where the heart is. It should be part of the screening. First thing you do while you're showing the mother the baby, identify your right and left, and make sure that everything is in the correct position. And in particular, we're starting from the abdominal situs, which is the first of our axial plane. So at the level of the abdomen, corresponding more or less at the level of T10, we should see the stomach on the left, the aorta to the left, the inferior vena cava to the right. We may see a little bit of the umbilical vein here. Now, why is this important? Because if everything is in the correct place, from the heart point of view, that has one meaning which applies to almost every case, but there are a few exceptions. But we are talking about general rules here. So normal abdominal situs comes with the right atrium being on the right and the left atrium being on the left. And that's all it means in terms of the sequential assessment of the heart. Now, if we move on from the 4 chamber, you're still looking more of the general aspects within the chest, like the heart size, about a third of the chest, the cardiac axis, the rhythm, the contractility. And I'm going to start with the cardiac axis, and that's a 4 chamber taken from that same clip. And if you draw a line from the anteroposterior axis and another line through the interventricular septum, that cardiac axis about 45 degrees, plus or minus 10 degrees, which is 1 standard deviation, or 20 degrees, which is 2 standard deviations. We don't obviously need to measure that. Our eyes get used to the image. Heart on the left, normal axis. And the rhythmic contractility, of course, needs to be seen on a moving image. We can't show that on this still frame. So we're going to talk about the rhythm and contractility together at looking at the real meat of the four chambers, the atrial chambers, the ventricular chambers, and the atrioventricular valves. And this looks like a very long list just to talk about the four-chamber view. So you can see how much you do need to go through, and that process is very quick once you do that many, many times and sequentially. So coming to our four chambers, still on a still frame, we need to see that the heart is on the left. We said through that. We need to see the four chambers, which is the name of the view. Symmetry between right and left-sided cardiac structures. We need to see the four chambers with two atria and two ventricle, two atrioventricular valve. But we also need to see that they open and close separately. We need to see the crux of the heart with the offset, i.e. the tricuspid valve closer to the apex, because that identifies the right ventricle, the moderator band in the apex of the right ventricle, the smooth apical portion of the left ventricle, the atrial septum with the foramen ovale, and its flap valve, which again is assessed on a moving image. So there we go for our four-chamber view. It's the same of the clip. So good contractility, the heart squeezes everything in systole and opens in diastole. There is symmetry, right and left more or less the same size, two valves open and closing. And remember that you do need to see those valves opening and closing separately. Very important for the assessment of atrioventricular septal defect. You can see the flap valve here at the back, good foramen ovale, and just seeing some pulmonary veins entering the left atrium. And that's a very easy because the baby's in a good position. But if you do that in every baby on a difficult patient, you'll be easier to go sequentially through all the findings. So outflow tract views, what we need to do is ascertain normality of the two vessels, the aorta and the pulmonary artery. And to do that, we follow that sweep. We start on the abdominal view, we move upwards towards the baby's head, and we move upwards towards the vessels, going sequentially through the four chamber, the left and the right ventricular outflow tracts, and the three vessel and three vessel trachea view. Now, to ascertain normality of the two vessels, we really need to show that each vessel connects to the appropriate ventricle. And I'm taking for granted here that you all know that the anatomy of the heart, the basic anatomy of the heart. Right ventricle to the pulmonary artery, left ventricle to the aorta. We need to look at their relative size and position, and we need to look at the adequate opening of the arterial valves in the same way as we need to see the opening and closing at the mitral and tricuspid valves. So basically, at a minimum, we need to see the two vessels are there coming off the appropriate ventricle and that they cross each other at their origin. And this simple way of looking at the outflow tracts can be very efficient. You won't exclude all the cardiac abnormalities, but it's the first step towards ascertaining normality. So let's move then to the first more specific view of the outflow tracts, the left ventricular outflow tract. What we need to see here, we need to see a vessel that arises from the left ventricle and has normal continuity between the septum and the anterior wall of the vessel. We do need to see a valve that opens and closes, and that is just about it. If we see that as normality of the left ventricular outflow tract, depending on the views you are, you may or may not see more of the aorta coming here. In this apical view here, we can see that this clip is very, very short because the aorta is starting to come just like the five-chamber view. It is wedged between the mitral and tricuspid valves. And you only need to tilt your transducer very, very gently to get that outflow tract. If you do it too quickly, you may miss a ventricular septal defect in this area, which can be foreshortened. So it's important to do it slowly, and if you're not sure if the baby's moving a lot, stop and review your clips so you can adequately see the continuity between the interventricular septum and the anterior wall of the aorta or the vessel arising from the left ventricle. Then we move to our right ventricular outflow tract. It's very difficult to split them into 5 different steps, particularly as we come to the vessel views, because they are so close together. And you see that some of my clips, there is a mixture between them. They merge with each other. So on the right ventricular outflow tract, we need to see a vessel which arises from the anterior ventricle, closer to the chest wall, and that vessel is shown to be the pulmonary artery. It bifurcates. Again, you see the bifurcation if you do that sweep slowly. We need to see a valve that opens and closes normally. You don't always see that bifurcation, but you need to see that vessel here. So this is moving from the left ventricular outflow tract into the right ventricular outflow tract to show your pulmonary artery and the bifurcation. You can see that you're already seeing here a little bit of your 3-vessel view. So you can't really stop and say this is one and this is another one. They are merged together, particularly the right ventricular outflow tract, the 3-vessel and the 3-vessel trachea view. They come one after the other sequentially. So we still have here, the beginning of this clip is a very, very short clip, but we go from the left ventricular outflow tract to the right ventricular outflow tract, the pulmonary valve here opening and closing. We can see that crossover. So left ventricle coming towards the right shoulder, right ventricle coming across at 90 degrees at their origin. We have here the left ventricle, the proximal aorta, and that's the aorta, already starting to come into your 3-vessel view. And we see here the bifurcation of the pulmonary artery. So even without wanting, we're already on the 3-vessel view, and that's basically demonstration of the pulmonary artery, aorta, and the superior vena cava, and I'll show you more details of that in a few clips more towards the end. But pulmonary artery, aorta, and SVC. And again, it's better to see that on a moving image. You can see that I can't get away from having my bifurcation there, the pulmonary valve. That's the pulmonary artery, the aorta, and the superior vena cava. So I like to show this very slowly so that you appreciate it. You can't really go like you go, this is an arm and this is a hand, because they're a long distance. These are very, very short distances. So you don't necessarily need to see absolutely everything, because it will vary with patient position, but you will have to see the essential to demonstrate that the vessels are normal. So that sweep that can last just a few seconds is coming up to its end towards the 3-vessel and 3-vessel trachea view, and that is also called an arch view. And this is just one step further, one step more towards the baby's head, which demonstrates the transverse aortic arch going from the proximal part of the chest towards the descending aorta. So it's a good view to look at the aortic arch, and it's a very close relationship with the trachea. The trachea is fluid-filled, and it's got a very bright echo around it because of this cartilaginous structure. We still have here the 3 vessels, even if we are on the trachea level. So very, very short clip. You can see how it goes just 2 seconds or less between the 3-vessel and the 3-vessel trachea view. So you only need to move your hand a tiny little bit more towards the baby's head, or sometimes you don't need to move. Baby moves, and there you have. And if it is too quick, remember to stop your clip and then dissect it into all the views. This is a very short clip that I'm showing you, and I'm spending already 20 minutes almost demonstrating just this 5 short axis sweep. Now I'm going to now show you a slightly different view of the left ventricular outflow tract and the 3-vessel and 3-vessel trachea view, which is with the heart, the apex pointed to about 9 o'clock here. And particularly if it is on this view, if you don't do an absolute transverse cut, but it's slightly oblique, just tilting slightly to the baby's right shoulder, you can elongate the left ventricular outflow tract a bit more, so you can see more of the proximal aorta. It's easier in a way to see the septo-aortic continuity. The other view I showed you, you can foreshorten very much this area, and you can more easily miss a ventricular septal defect. So look at the heart from different angles as well. Is another tip for getting your good screening. That's the aortic valve, and when you're doing the outflow tract, make sure that you do see the valve open and close. And open, when it opens you don't see it, and when it closes you just see the thin leaflets of the valve. So that's part of your left ventricular outflow tract. And then just tilting a little bit more, we come to the right ventricular outflow tract, and the same applies here to the pulmonary valve. We need to see it closing, and we need to see open. It's a good idea, if you make lots of measurements, to start measuring the valves so that you get familiar with how to measure them and how to see them. Just include that on, it's not on our guidelines yet, but maybe the next one will include measurements. So that's the right ventricular outflow tract. This is the aorta, and so don't just memorize that that's the aorta. Go back to your clip and you can see the aorta coming off the left ventricle, and if you keep an eye on here, you can see that that will become the aorta in short axis view. And to the right of that, we have the superior vena cava. And if we had gone down to the fourth chamber, we could follow that right superior vena cava onto the right atrium. So this is a diagram here that will show us the diagrammatically the three vessel structures, the pulmonary artery, aorta, and superior vena cava. And we need to assess quite a lot of things on these: vessel size, vessel number, arrangement, and alignment. And here they are, from left to right: pulmonary artery, aorta, and superior vena cava. So this is our diagram. Of course, like in the four chambers, we need to see four chambers. On the three vessels, we need to see three vessels. That's obvious. But we need to see more than just counting the vessels. Their arrangement, as I said, in that order, from left to right, is pulmonary artery, aorta, and superior vena cava. We need to see the vessel size. The pulmonary artery is usually a little bit bigger than the aorta, which is a little bit bigger than the superior vena cava. We don't go measuring that because sometimes the view is slightly oblique as well. And the vessel alignment, which is they form more or less a straight line here from anterior-posterior, the straight line with the pulmonary artery being more anterior, the aorta more or less in the middle, and the superior vena cava more posterior. And following from that clip, just again a few millimeters above the three vessel view, we come to the trachea with the aortic arch. And if you go down a little bit, you can see that trachea dividing here into the two right and left main bronchi. Sorry? Yeah. So there we are, the trachea and the aortic arch. And if we had from the start identify your left and right, you know that there's a left side the aortic arch, which is a normal position of the aortic arch. Now, you will see on the guidelines that there is a symbol there. That means there is more material on the internet. We were aiming to put some clips there, but we haven't got around to doing that yet. But you have lots of clips on this lecture which you can watch if you want. But there are some additional pictures if you go through the internet, which are mainly on B-mode panels, and there's still image and color flow panels, just giving slightly different aspects of the outflow tracts. Now, the guidelines, they've just been released, but there is a date for review, which is in about 3 years' time. So maybe we'll choose Berlin again for 2016. And we have not included color on the guidelines, and we agreed and disagreed many times, but at the end came to a conclusion that was a bit too much for guidelines that are meant to be international and apply to many, many countries. But you would all agree that color does add something. And if we start working on the color now, maybe by the time they come into force for the guidelines, you will be familiar with that. I am just going to go back through my slides before I finish, because I should have pointed out there were two mistakes, Rabbi said two, I'm only aware of one, on the PDF you received. And that's because you're very special, because before we had the final proof for the print version of the guidelines, Rabbi wanted them. Can I have the guideline? Can I have the guidelines? So it was sent to him before, the very last reading absolutely every single word, checking absolutely everything. And there's a prize. If anyone looks here, tell me, spot one difference. We've corrected. This image is correct. So I'm just going to bring me back to that, because if you go through the PDF version you have on your CD, that picture here, on the three-vessel trachea view, there was a mistake there. Yeah, just the order of it's a minor thing, but it has been corrected. So it's going to come to print correctly, and the PDF versions that you will be able to download subsequently, but not on the one on your disk. Here is pulmonary artery, aorta, and superior vena cava, and on the PDF you received, the aorta and the pulmonary artery was swapped, and it's not transposition. Thank you very much for your attention.
Thank you.